Welcome to the deep dive. You asked for it, so here we go. A high-yield revision deep dive on Ehlers-Danlos Syndrome, EDS.
That's right.
Our mission today is pretty straightforward. Pull out the essential info you need on EDS efficiently.
Get you exam ready.
Exactly. We'll cover, the definition, causes, how it shows up, the bigger picture.
And we've got some memory aids, too.
Definitely. Got some tricks to help make it stick, so ready to tackle EDS.
Let's do it. Okay, so starting with the basics, what is Ehlers-Danlos Syndrome?
Good place to start.
Well, it's not just one thing, really. It's a group of genetic disorders, and they all fundamentally affect the body's connective tissues.
Connective tissues.
Yeah.
So like the glue holding everything together?
Pretty much. These tissues are packed with a protein called collagen, and they're the structural support for, well, everything: skin, joints, blood vessels, you name it.
Yeah.
And the classic signs, the things you often see with EDS, are joints that are overly flexible, maybe skin that stretches more than usual.
Right, the hypermobility and stretchy skin.
Exactly. And also skin that's quite fragile, maybe bruises really easily or tears easily.
So it's not just one single condition then. I think I remember reading that while, you often see that increased tissue elasticity and joint hypermobility, and it's often linked to type 3 collagen issues and autosomal dominant inheritance, there's actually more to it.
Absolutely. That's a key point. The diversity within EDS is, well, it's quite striking. We now recognize 13 distinct subtypes.
13.
Yep, 13. And each one has its own sort of unique clinical picture and genetic cause. They range from quite mild forms, maybe mainly affecting joints, to much more severe types that can have really serious consequences for organs, especially like the vascular subtype.
Okay, so finding the exact subtype is important.
Crucial. And that often means genetic testing to find the specific mutation. Although it's worth noting, for hypermobile EDS, the most common type, the diagnosis is still clinical because the genetic basis isn't fully known yet. But having these 13 subtypes really shows you why diagnosis can be tricky and why management needs to be tailored, based on the specific genetics involved.
Can you give us just a couple of examples of subtypes just to illustrate that variety?
Sure. So take classical EDS. We often see mutations in genes like COL5A1 or COL1A1.
Okay.
Then there's vascular EDS, which is linked to COL3A1 mutations. That one carries a higher risk of serious issues with blood vessels.
Right. The name suggests that.
Exactly. And then, as I mentioned, hypermobile EDS, super common, but the genetic link is still a bit of a mystery.
Huh?
And to help sort through all this, clinicians use specific sets of major and minor clinical criteria for each subtype.
Got it. So the root cause, the etiology, is fundamentally these genetic mutations affecting collagen.
Precisely. EDS is primarily caused by genetic mutations that mess up either how collagen is made synthesized or how it's processed afterwards.
And collagen is the key structural protein.
Absolutely vital for the strength and integrity of connective tissue. You can think of collagen molecules like building blocks. The genes give the instructions for making and putting these blocks together.
Right.
In EDS, those instructions are faulty, so you end up with abnormal collagen being produced.
Which leads to the symptoms.
Exactly. That's what causes the joint hypermobility, the fragile skin, all the features we see. And the most common way it's passed down is autosomal dominant.
Meaning just one faulty gene copy is enough.
Correct. One copy from one parent is usually sufficient, though there are rarer forms that are recessive or X-linked too.
Okay, if it's genetic, then I guess family history has to be a major risk factor.
That's a really key point, yes. Because EDS is inherited, having a family history is definitely a significant risk factor.
Makes sense.
And understanding the specific inheritance pattern in a family, is it dominant, recessive, X-linked, that gives important clues about the risk for other family members.
Right. A 50% chance for each child in dominant inheritance, for instance.
Exactly. While family history is the big one, you might also find specific risk factors tied more closely to particular subtypes, but the genetic link is paramount.
Okay, so we've got the what these genetic mutations and the who in terms of family risk.
Yeah.
Let's dig into the how a bit more. The pathophysiology. How do these genetic glitches actually cause the symptoms?
Right, the mechanism. Well, what's really going on is that these mutations in the collagen genes mean the body produces collagen that just isn't quite right.
Also,
It might be structurally wonky, or maybe there isn't enough of it, or it doesn't get processed correctly after it's made.
okay.
And this faulty collagen then weakens the whole structure of the connective tissues wherever they are in the body. I sometimes think of collagen as the body's scaffolding.
Ah, that's a good analogy.
Yeah, if that scaffolding is weak or built incorrectly, you'll see problems in the tissues that rely on it for strength and support.
Which explains the symptoms like loose joints.
Exactly. Joint laxity, fragile skin, tissues prone to injury, and potentially problems with internal organs, too. The key thing is how these tiny genetic errors ripple outwards, affecting structure body-wide.
That makes a lot of sense. But given how varied the symptoms can be, diagnosis must sometimes be a bit of a puzzle, right?
Yeah.
What else might look like EDS? What's the differential diagnosis?
That's a really important question because, yes, the overlap in symptoms can definitely make diagnosis challenging sometimes. EDS is a connective tissue disorder, so naturally, other conditions in that same family are high on the list.
Like Marfan syndrome.
Precisely. Marfan syndrome, osteogenesis imperfecta, brittle bone disease, they can share features, especially around joints in the skeleton. And then you have the hypermobility spectrum disorders. These mainly involve joint hypermobility, but might not have the same level of skin fragility you often see in EDS.
So similar joint issues, but maybe less skin involvement.
Often, yes, but it's a spectrum, as the name suggests.
Are there others beyond those sort of classic connective tissue disorders?
Yes, definitely. You might need to consider things like Loeys-Dietz syndrome or various cutis laxus syndromes. They can have skin and tissue findings that overlap with some EDS types.
Interesting.
Even something like autosomal dominant polycystic kidney disease could potentially be considered in some contexts. And it's also worth remembering conditions that might seem unrelated, like fibromyalgia or chronic fatigue syndrome.
Why those?
Because the chronic pain and fatigue that are so common in EDS can look very similar. So recognizing these potential mimics is really crucial for getting the diagnosis right.
Okay, good to keep those in mind. So how common is EDS then? What does the epidemiology look like?
Well, the overall estimate for all types of EDS combined is somewhere between 1 in 5,000 and perhaps 1 in 250,000 births. Quite a wide range.
Yeah, that is why.
And interestingly, there seems to be a gender difference reported roughly 8 women affected for every 1 man.
Oh, really? That's significant.
That's what the figures suggest, though the reasons aren't entirely clear. And when you break it down by subtype, the frequencies vary hugely. Well, classical EDS is maybe around 1 in 20,000 to 40,000 people. Vascular EDS is much rarer, maybe 1 in 250,000.
Okay.
And some types like arthrochalasia and kyphoscoliotic are incredibly rare, fewer than 100 cases ever reported for each.
Wow.
And dermatosparaxis is the rarest, only about 10 cases known worldwide. So it really runs the gamut from relatively common to exceptionally rare.
Those numbers definitely put it in perspective. Right, let's move on to what someone with EDS might actually experience.
Yeah.
What are those typical clinical features we should be looking out for?
Okay, clinical features, as we've kind of hinted, they vary massively depending on the EDS type and how severe it is for that person.
But there are common threads.
Oh, yes. Joint hypermobility is a big one, often leading to frequent dislocations or partial dislocations, subluxations.
Right, the joints popping out.
Exactly. And fragile skin that tears easily, plus bruising really readily, sometimes with hardly any knock at all. That's very characteristic too. And many, many people with EDS deal with chronic pain, which can be really tough. Gastrointestinal problems are also surprisingly common, things like IBS symptoms, acid reflux.
Didn't you mention cardiovascular issues earlier?
That's right, yes. Potential problems like aortic regurgitation, where the main valve leaving the heart doesn't close properly, or mitral valve prolapse. These are definitely concerns, especially in certain subtypes like vascular EDS, where they can be quite serious.
Okay, that's important.
What else? Well, there's a whole range. In some types, there's an increased risk of subarachnoid hemorrhage bleeding around the brain.
Serious stuff.
Definitely. Also, symptoms like dizziness, abdominal pain, hernias are more common. You might see eye issues like nearsightedness or blue sclerae, where the whites of the eyes look bluish. Hearing problems can occur too.
Wow, it really affects multiple systems.
It does. Urogynecological issues like pelvic organ prolapse, especially in women. Fatigue is huge. Anxiety is common. Even things like the jaw joint, the TMJ dislocating, and obstetric complications during pregnancy.
That is quite a list. It really highlights how widespread the effects of faulty connective tissue can be. Is there any way to sort of chunk this down for revision? A mnemonic, perhaps?
Funny you should ask. Mnemonics can be really helpful here. How about this one? Jesuit PG Choates.
Jesuit PG Choates. Okay, that's memorable. What does it stand for?
Okay, so J for joints, hypermobility. E for elastic skin,
Hmm.
S for skin fragility leading to easy bruising, P for pain, chronic, G for GI issues,
Okay, Jesuit PG.
then C for cardio-aortic regurgitation, MVP, H for hemorrhage, like subarachnoid, O for ocular issues, A for anxiety, T for TMJ dislocation, and the final S for, oh wait, let me recheck that last bit. No, I think I missed obstetric complications in my initial mnemonic creation. Let's adjust. But Jesuit PG CHODIS. Joints, elastic skin, bruising, skin fragility, pain, GI, cardio, hemorrhage, ocular, anxiety, TMJ. Still missing obstetrics. Maybe the mnemonic needs work, or we just remember the key categories.
Huh. Okay, well, Jesuit PG Chot was close. Maybe the key is just remembering joints, skin, pain, GI, cardio, and then the other potential system involvements like vascular, ocular, obstetric.
That works too. The goal is just to trigger recall of the main clusters of symptoms. The exact mnemonic isn't sacred.
Fair enough. So if someone presents with a bunch of these features, what investigations are typically done to actually pin down an EDS diagnosis?
Right, the diagnostic pathway. It really hinges on a good clinical evaluation first. That means taking a really detailed medical history, including that crucial family history, and doing a thorough physical exam.
Assessing the joints and skin specifically.
Exactly. Checking the Baton score for hypermobility, looking at skin texture, stretchiness, scarring, bruising. That clinical picture is key.
And then genetics?
Then the genetics comes in. Genetic testing is vital for confirming the diagnosis and identifying the specific gene mutation for most EDS subtypes.
But not all. You mentioned hypermobile EDS.
Correct. That's the big exception. For hypermobile EDS, or hEDS, the diagnosis is still primarily clinical. It's made by a specialist, usually a rheumatologist or clinical geneticist, based on a specific set of criteria from 2017, because, like we said, the underlying genes just aren't known yet.
So genetic testing isn't always the definitive answer, even for the other types.
Well, it's recommended for confirming non-hEDS subtypes, and it helps differentiate them. But sometimes, even if someone clearly has features of a specific subtype, current testing might not actually find the causative mutation. The technology isn't perfect, or there might be genes we don't know about yet.
Okay, that's important to realize. Are there other tests besides clinical exam and genetics?
Yes, depending on the situation. Doctors might order imaging like x-rays for joints or an echocardiogram to look at the heart and aorta.
Especially if suspecting cardiovascular issues.
Exactly. Skin biopsies are sometimes done, looking at collagen structure under a microscope, though that's less common now with better genetic testing. And other specialized tests might be needed to check specific organs if there are concerns like vascular imaging, if vascular EDS is suspected. Very rarely, for specific subtypes, enzyme assays might be used.
Okay, comprehensive approach. So once someone is diagnosed, what can actually be done? What's the management strategy, especially thinking about the UK system?
Management in the UK, and generally worldwide, really focuses on a few key things. Managing the specific symptoms the person has, preventing complications where possible, and using a multidisciplinary team.
Not just one specialist then.
Definitely not. You need a team. Key parts of management usually involve physiotherapy. That's huge.
For the joint instability.
Yes, to strengthen muscles around unstable joints, improve proprioception, your sense of where your joints are in space. Pain management is another major pillar.
Which can be complex, I imagine.
Very. It might involve medications, more physio-psychological approaches like CBT. Braces and supports can be really helpful too for stabilizing joints. And careful skincare is important to prevent injuries.
Is surgery ever an option?
Generally, it's avoided if possible because tissues can be fragile and healing might be poor. But it's sometimes necessary for specific complications like recurrent dislocations that don't respond to physio or obviously in emergencies like a vascular rupture.
Are there any specific treatments or meds that stand out?
Well, physiotherapy, as I said, is cornerstone for joint issues. CBT can be really valuable for coping with chronic pain and the psychological side of things.
Right.
For pain meds, often it's the standard analgesic ladder approach. For vascular EDS specifically, there's evidence for a beta blocker called celiprolol. It seems to reduce the risk of major vascular events.
Oh, that's quite specific.
It is. And careful skincare, like avoiding trauma, using protective padding maybe. Some people find vitamin C, ascorbic acid helps a bit with bruising, though the evidence is maybe not super strong. And critically important is genetic counseling for the individual, for their family, to understand the inheritance, the risks, future options.
Absolutely essential. So looking long term, what's the outlook? What's the prognosis typically like for someone with EDS?
It's really highly variable. It depends massively on which subtype they have and just how severely they're affected as an individual.
Okay.
For most types, the actual lifespan is generally considered normal.
That's reassuring.
It is. The big, stark exception is the vascular type. Because of that risk of major blood vessel or organ rupture, vascular EDS unfortunately often carries a reduced lifespan.
Right, that's the really serious one.
It is. But for the other types, while lifespan might be normal, the impact on quality of life can range hugely. Some people with milder forms might just have bendy joints and need to be a bit careful. Others can face significant disability, chronic pain, and real challenges with daily living due to multiple system involvement.
And it can vary even within a family.
Absolutely. Two people in the same family with the same mutation can have quite different levels of severity and complications. It's complex.
Okay. And finally, thinking about those complications, what are the main things that can go wrong that we need to be aware of?
Well, again, it depends on the subtype, but common complications involve multiple systems. Frequent joint dislocations and subluxations are a big one, leading to chronic pain and joint damage over time.
Right.
Those vascular problems we mentioned, arterial dissection or rupture, are the major life-threatening risk, mainly in vascular EDS, but occasionally seen in others.
Okay.
Organ rupture, like the bowel or uterus, can happen, again, more common in certain subtypes. GI issues like severe constipation, gastroparesis, or diverticulosis can cause significant problems.
And pregnancy.
Pregnancy can carry increased risks, things like premature rupture of membranes, difficult deliveries, postpartum hemorrhage, or even uterine rupture in severe types. So careful planning and monitoring are essential. You really have to think about how interconnected everything is with that faulty connective tissue.
Definitely. Okay, so to quickly recap then, Ehlers-Danlos Syndrome isn't one thing. It's a group of inherited connective tissue disorders, mostly down to faulty collagen.
Right. 13 types currently known.
Mostly genetic causes identified, except for hypermobile EDS. Huge range of features: joints, skin, pain, GI, cardio.
Don't forget the potential for vascular ocular obstetric issues, too. The Jesuit PG CHOAS attempt?
Yes. Diagnosis involves that clinical picture plus genetic testing usually. Management is multidisciplinary, symptom-focused, preventative.
Physio, pain management, support.
Prognosis varies hugely by type, generally normal lifespan except for vascular EDS, but quality of life impact can be significant, and complications could affect many systems.
You got it. And maybe a final thought to leave people with, considering collagen is basically everywhere in the body, what other, maybe seemingly unrelated symptoms might actually make you pause and wonder about an underlying connective tissue disorder like EDS?
That's a really good point. Food for thought. Right, for everyone listening and wanting to cement this knowledge and find more revision resources, definitely head over to passmsray.com.
And freemasray.com as well.
Absolutely, great resources there. Thanks so much for joining us for this deep dive into Ehlers-Danlos Syndrome.
My pleasure.
Until next time.